Welcome everyone to the 5th session of the CDC CHI Unitaid Advanced HIV Disease Learning Series. Today's session is going to focus on TB preventive therapy, policy, research, options, implementation, and best practices. I'm Bruce Strumminger with Project ECHO at the University of New Mexico, and I'm just going to run through a few housekeeping items before we launch into the formal program. Next slide, please. We do have French interpretation for our Francophone colleagues. And if you go down to the bottom right of the Zoom toolbar, you'll see a globe icon with interpretation underneath. And if you click on that, you'll then be able to select French and hear interpretation there. Next slide. If you're having any IT issues or other logistic issues, please mention those in the chat. We'll try to help you out as best we can. We really look forward to all your questions on this super important topic of TB preventive therapy. Please put those in the Q&A feature, and we'll be monitoring that and hope to get to as many as we can. We'll be answering those both in writing and hope to get to some of them for live discussion. The presentation slides and a recording of today's session will be shared on the website supporting this Advanced HIV Disease series, and we'll share that in the chat. All the recordings of prior sessions and the PowerPoints, et cetera, can be found there. Next slide. We are recording today's session as we always do for this series, and your attendance is consent to be recorded. Thank you for that. We're offering continuing medical education and a certificate of attendance through the University of New Mexico, where Project ECHO is based. And we'll put a link in the chat to the brief survey that'll take 2 or 3 minutes to complete. And you'll have 48 hours to complete that. We really appreciate your feedback about the quality of these sessions and the topics and what topics you want to learn about in the future. So we encourage you to take advantage of the opportunity for the CME and the certificate of attendance, and please give us your feedback on how we're doing. Next slide. Really, please, and want to encourage everyone, if you can, to scan this QR code as a way of marking your attendance. It also is super important for those who want the CME to verify your attendance in the session. So if you've got a QR code scanner on your mobile phone, if you just point it at that QR code and literally just fill in your name and email address, that will really help us with the tracking of attendance and matching up of who was here with who is requesting the CME. So we appreciate that. Next slide. So just a word about data use. When you register, the data you share with us, when you also put questions in the Q&A, et cetera, we take data stewardship very seriously, and we keep your individual data confidential. So just want to ensure everyone we take that very seriously. Next slide. So with that, it's my pleasure to hand the microphone over to Ike Amemala, and he's going to be moderating today's session. Ike's with CHI. Over to you.
Thank you very much, Bruce. Welcome, everyone. Pleased to be part of this very important session today. As Bruce mentioned, today's session is dedicated to the critical subject of tuberculosis preventive therapy. We have a packed agenda, as you can see, with a spread of topics and speakers to cover this very important subject. My name is Ike Chukwuamamile, IK for short. I'm a senior technical advisor on advanced HIV disease with the Clinton Health Access Initiative, and I'll be your host today. CHI's work on advanced HIV disease is made possible through the generous support of Unitaid. For today's session, we'll start with an overview from the World Health Organization on the evidence, guidance, options, and research gaps for TPT. Next, we'll move on to hear from the Aurum Institute about the Impact for TB project. This will mark the end of the first segment of this call, and we'll follow up with a question and answer. After that, we'll move to an implementation-focused session for the call. We'll hear from two ministries of health in Africa. First would be Zimbabwe, and second would be Uganda. We've listened to feedback, which is why we're implementing this two-pronged question and answer session. So while filling the survey at the end, do let us know if you prefer this or you like the single question and answer session at the end. Without further ado, I'd like to welcome our first speaker. Ajay Ranjaraj is the technical officer at the World Health Organization in Geneva. He's the lead for advanced HIV disease. He also supports the World Health Organization's response in the ongoing COVID-19 pandemic. Ajay is a clinician with a degree in public health from the London School of Hygiene and Tropical Medicine. Ajay, you're welcome.
Thanks, Ike. Hi, everyone. Great pleasure to be part of this ECHO webinar, and I'll, without further ado, I'll get started. So today, asked to speak about, TPT in the context of AHD, evidence, guidance, options, and research gaps. So moving on. So just wanted to put some definitions in here because I think it's useful for all who are dialed in. Just to say that advanced HIV disease is adolescents and children greater than 5 years old is defined if they have a CD4 cell count less than 200 cells or have a WHO clinical stage 3 or 4 event. And it needless to say, all children with HIV younger than 5 years should be considered as having advanced HIV disease. And we often use severe immunosuppression or profound immunosuppression. So this is largely defined as less than 50 cells per millimeter cubed. And again, TPT is treatment offered to individuals who are considered at risk of TB disease in order to reduce that risk. It also is often referred to as LTBI, or just generally preventive therapy. And also some abbreviations at the bottom for your reference. So again, I just thought I'd put these two issues side by side so you can kind of get a sense of scale of the problem here. So again, when it comes to tuberculosis prevention, we know that this is a huge challenge, and the recent global TB report also estimates that suggests that nearly a fourth of the world's population have been infected with TB at some point. And that true number is really almost impossible to estimate, but the modeling suggests that this is what this number is the leading cause of death among people living with HIV. And we see between 177,000 to 200,000 deaths among people with HIV. We know that TPT does reduce TB incidence, and also particularly in people living with HIV, it does reduce mortality by up to 37%, as seen in the Temprano trial. And also we do have this goal of 88% of the United Nations high-level meeting target of 6 million TPT worldwide was really provided to PL-HIV on ART. But I think it's worth noting that overall access globally does remain very low. So now when you switch over to advanced HIV disease, we typically see it's associated with very high mortality, typically within weeks of diagnosis, even on ARVs. It's responsible for, as per recent UNAIDS estimates, up to 700,000 deaths in 2019. Although it has greatly reduced, but this is still an unacceptably high number. And it is the leading causes of mortality. Again, this is where tuberculosis comes in, which is the leading cause of mortality among this group of patients who have advanced HIV disease. So you have TB, cryptococcal meningitis, and then followed by severe bacterial infections. We now know that for a multitude of reasons, the outcomes are worse in men than in women. And 56% of people with an estimated HIV incident TB have actually accessed care. So again, we know that these are problems that really disproportionately affect low and middle income settings. And really it's really both have this challenge of access. So in the case of TPT, it's accessing patient-friendly preventive options. In the case of AHD, it's accessing that package of care. And people living with HIV are 15 to 21 times more likely to develop TB than in the general population. And there are multiple barriers to scale up. And so the next issue is when it comes to advanced HIV disease, there is this nested problem of those who have cryptococcal meningitis who also develop TB. So this represents another sort of specific micro challenge inside advanced HIV disease. And also we know that a large proportion of deaths are really due to an unidentified cause. So just wanted to show you that there has been a large global public health response in the case of TPT, as well as of course, needless to say, HIV. And there's been a multitude of targets, including the SDG targets, WHO NTB strategy, as well as the UN high-level meeting on TB. But I think the challenge is that we have sort of fallen short of these challenges, and COVID notwithstanding, and I think COVID has further affected this problem even more. So yeah, and I think so. Just to show you that the target really is to achieve 30 million people across all ages with TPT, and currently we have achieved 21% of that target as of 2018-2019 data. And moving over to HIV, I think it's worth noting that we do have the UNAIDS 1990 initiative, which is people living with HIV who know their status is the first 90. The second is people living with HIV who are on treatment. And third 90 is people living with HIV who are virally suppressed. So I think we still have fallen short of these goals, although some countries have achieved, and now it's been revised to 95, 95, 95. We know that we have better ARP regimens, which are more efficacious and durable, and these are currently being scaled up in national programs. And we also know that we have fallen short. So I think this sort of represents a general challenge across these two areas of work. So again, sort of looking at the intersection of these two diseases, intersection of TB preventive therapy and advanced HIV disease. So we know that TB is responsible for a very large proportion of deaths. And you can see that it's the second most frequent cause other than just overall AIDS related mortality. It's the leading cause in both adults and then also in children. And again, as I said, I just want to reiterate that we do know that TPT can profoundly affect survival in the case of people living with HIV. So I think we did have some questions come in early on. So they said, sort of wanted like a kind of breakdown of the various regimens that are available for TPT. And, I just wanted to put this out here to just say, these are not necessarily all of the regimens that are recommended, but I just wanted to sort of work through the abbreviations quickly. So IPT essentially refers to isoniazid monotherapy, and this can be for 6 months or 9 months. So when you say 6H or 9H, it essentially refers to the duration and age referring to isoniazid. And in the case of R, it refers to rifampicin monotherapy, which could be up to 4 months. 3HR refers to the combination of isoniazid and rifampicin. The newer preventive options include 3HP and 1HP, which essentially consist of isoniazid and rifapentine. So what are the current WHO recommendations for TPT? So in this case, I'm focusing purely on people living with HIV. So really our criteria here is we're really not concerned of whether they're receiving ARVs or not. They have to just receive TPT. I think it's really important to stress that point. Pregnancy, previous TB treatment, and any form of immunosuppression, and really availability of a test for TB prevention is should not be a barrier to providing TPT. So I think, again, it's worth mentioning that, again, it's important to rule out TB was the next logical step. So in the case of people living with HIV, we're really looking for no current cough, fever, weight loss, or night sweats. Additionally, chest X-ray may be used to help improve diagnostic ability. And again, I just want to reiterate, we are not looking to, a test is not a pre-requirement to initiate TPT in this case. And this is also the latest guidance available, came out in 2020, and it's module 1 prevention of tuberculosis preventive treatment. And again, I want to reiterate that chest radiography is not a barrier for initiating preventive treatment. Now coming on to the specific regimens that are currently recommended, WHO recommends several regimens, which include 6 to 9 months of daily isoniazid monotherapy, 4 months of daily rifampicin, 3 months of daily rifampicin plus isoniazid, 3 months of rifapentine and isoniazid weekly. That is 12 doses, or this is known as 3HP, and of course 1 month of rifapentine plus isoniazid, although we have less information on this particular regimen. And also, we do have recommendations for MDR-TB, which I know a lot of people were curious about, but really our evidence is quite limited based on clinical judgment, and really should be based on clinical judgment, as we have very limited information on its safety profile. Again, management of missed doses, really, I think the stress is if it's less than 2 weeks, you just need to calculate the extra number of days that you need to give the missed doses for. And I think any duration greater than, there are specific nuances, but I think it is important to reconsider restarting TPT if there has been a significant interruption. Coming to advanced HIV disease, really, we recommend a package of interventions, which really include screening interventions, treatment, and/or prophylaxis for major opportunistic infections, rapid ART initiation, and intensified adherence support, and should be offered to everyone presenting with advanced HIV disease. I think it's also very strongly supported by other recommendations, which is sort of offering same-day start and also rapid initiation of ART for all people living with HIV. This is the document released in 2017. And of course, we have made some edits to the rapid initiation caveats. And this is will be released later this month. And so what's in the box, really? So what are the components of the package of care? So it includes, again, diagnostic, which could be a sputum expert, MTB, LF-LAM, cryptococcal antigen screening, also prophylaxis and preemptive treatment. So this includes cotrimoxazole, TB preventive treatment, and fluconazole preemptive therapy for cryptococcal meningitis. And ART initiation, needless to say, and of course, adaptive adherence support are all very critical components of this package. And LF-LAM really in this case should be viewed as an additive rather than as the primary test for which you should be using to check for profound immunosuppression. And empirical azithromycin does not feature in the package, and this was mainly around concerns for antimicrobial resistance and is a continuing dialogue at WHO. So I just wanted to show you like really where the two different algorithms. So this is the one for advanced HIV disease. And I just want to direct you to this section of the algorithm where we're really looking at thinking about either treating for actual TB disease or providing TPT. And when you look at the, from the consolidated guidelines for TB, this is the algorithm. So you really are, I think that it's all geared towards providing TPT as quickly as possible and as effectively as possible. And really in a recent rapid communication, I think the global TB department has also included chest X-rays to help improve the sensitivity of the 4 symptom screening, which is what, of cough, fever, weight loss, or night sweats. And CRP may also be used additionally for TB screening over and above the WHO symptom screen. And I'll just move on. And again, now how long does TPT protect for? So we do have some longitudinal studies that have provided some insight into this. And typically the range is believed to range between 60 and 90%. So in summary, as far as TPT goes, INH resistance following TPT, there's really no likely increased risk as per the recent systematic review. No increased risk of resistance with intermittent rifamycin. Very small proportion develop adverse events, mostly self-limiting. So shorter regimen may be more favorable and likely lasting protection between 6 and 19 years. And again, this just sort of represents the pipeline of studies. I won't get too much into it because my colleagues will be speaking further down in the call. And again, what did we learn from these studies? As many of these studies were published at CROI 2020. I won't dwell on these, as I suspect many of these will be touched upon. And here's sort of a pipeline of ongoing trials. Just wanted to direct you to a couple of the ones that we're watching. One is the 2R2, that is the high dose rifampicin for 2 months versus standard 4R, the TBTC or asteroid study, which is the rifapentine versus 3 to 4R, and WIP3TB, of course, which we'll be hearing about, and then 1 HP versus 3 HP as well. And these are the ones that we're sort of looking for in terms of drug-resistant TB, which includes the TB Champ, Vequin, and Phoenix. Again, just to summarize on the research gaps, we're really looking for a simplified, from the AHD perspective, is I think the focus is really primarily on diagnostics and getting people onto TPT in short. And then I think for the TPT, I think the really important ones are in further information on children, shorter regimens, and also really more data on MDR TB prevention. And also we're really looking forward to the results of DOLPHIN too. And really looking to build back better post-COVID, increased interest in long-acting formulations. And I think the CAB-LA story for HIV is something to be followed. And we know that the LEAP TB working group has developed a target product profile and also commercialization products to help improve longevity. And we also are planning to release a webinar shortly for our new guidelines, which include ART initiation for people being treated for tuberculosis as well. And I encourage you to join in if you can. We have apps to help support and inform as well, and feel free to download them. They're available on all major app stores. Thanks very much.
Thank you very much, Ajay, for that packed and succinct presentation. Moving on nicely to our next set of speakers, which is from the Aurum Institute. I would welcome Karen Turner and her colleague, Violet Chihota. Karen is the current International Division Director at the Aurum Institute, and she has over 20 years of experience managing health systems, infectious disease, and United States government PEPFAR-funded programs throughout Africa. She's currently the director of the Impact for TB project at Aurum, which we're going to be hearing about in a bit. Violet is a senior scientist with Aurum. She as well has over 20 years of experience in biomedical sciences with specific expertise in epidemiology and implementation research. She is the lead implementation research focus point for the Impact for TB project. Karen, I believe you'll be starting first, so I'll hand it over to you. You're welcome.
Thank you. Thank you. So to start this one out for everybody on the call, welcome and thanks for that introduction. We decided to do something a little bit fun. Maybe I should have started with what does the acronym Impact for TB stand for, but I did some others for an introduction to what we're going to talk about today. So I'm going to go and invite the group to join a poll of 3 questions. And I think you all will get instructions from the team at ECHO on how that works as they put up the poll. So first, one of the big issues we were dealing with before 3HP came in was how many tablets a patient has to take. So I wanted to see from the group, how many tablets does everybody on this call think a single course of 3HP is? Which choices would you make there? If everyone can start, I'm going to wait a bit for answers to see who covers the correct one. We were trying to get less pills in patients, but if you were a patient needing to take this medicine over 3 months, what would be your total intake of the current regimens that are out there, which is a Sanofi product, Preventive? Okay, seeing some movement, Okay, interesting. Okay, because we were trying to decrease the pill burden, but there's a lot of pills listed there, hey? Okay. Great. Okay, I'm going to pause it because it's kind of hovering around the same percentages. So the answer's coming in the presentation. So I will verify that as we go. Okay, next question. I wanted to know, so there's even a newer regimen that's come out about just recently in the last few months. It's a fixed dose combination of 3HP. So how many countries have patients started on this regimen? You may be from potentially some of those countries that have ordered it. So how many do you think? Okay. Yep, 0, 6, 9, 11, or 23. Okay. Interesting. Keep it going for a little bit more. Okay, so most people are thinking it's about 6 countries that have started the fixed dose combination. Okay, answer will be forthcoming. Last one is price. Price mattered, and the access to this price was a significant push that we helped with other partners. I'll explain. But what do you think the original price of a full course of 3HP was? And I'm going to benchmark it in 2017. Before we truly began this project, what was the price of a full course of 3HP, only really available in just a handful of countries? I hope the people that are from CDC on the call would know this. Okay. I have to admit, it's kind of a bit of a trick question, but Okay. Great. All right, thanks. So that was the beginning. Now I'll give you some of the answers as we go through our slide presentation today. So let me pull this up. Okay. Can everyone see the presentation? And I want to make sure I'm seeing it in the right mode. Hold on a second. Okay.
Karen, hey, Karen, can you go up
Yeah.
to the display settings and do that?
Oh, I have to do my trick again. Sorry. Okay. I'm not seeing the display setting now. Just one second.
Keep going up. There.
Wait, hold on. Let me
Click
stop
on the
share.
Drop down.
Yeah, it's not popping up. Hold on. I'm not
to
seeing
your
the same
right.
thing you guys have right now. Hold on. Sorry about that, guys. Okay. All right, you're still seeing it in the same mode.
With the next slide. Yeah, if you can go up to that display settings and just click the caret to the right.
There it goes. Got it. Okay, so that should be it. Sorry. So first off, for the impact for TB, the secret acronym there was increasing market and public health outcomes through scaling up affordable access models of short course prevention therapy for TB. So it's quite a loaded one, which is why we use Impact for TB today. I'm just going to give a brief update on where we are with the project, and Violet's going to give a lot more information on the evidence. So it's about a 59 million four-year project that had procurement money in it, about $18 million. It's focused on the supply side of work with global capacity of developing new rifapentine-based formulations, delivery of those formulations, primarily 3HP. We're going to estimate about 1 million people will start on 3HP across 11 countries. There will be evidence generation that Violet will talk about on TPT across these different populations, and possibly also in pediatric and pregnant women in extension. And right now our project goes until 2021, but we're working with our donors at Unitaid, which are we're very grateful for this, proposed an extension for 2 years to get some things done that COVID and supply delays put in pause for us. So you all may be from some of these countries. We started in 12, low income, middle income, high income, picked for high TB burden. The partners working on this project, the prime is Orem, working with KNCV, Hopkins, and CHI at country level. TAG is also supporting us with some significant CSO support, and GDF as well. I've highlighted Tanzania in yellow for us because we're still in a period right at the end of the grant period where Tanzania has not fully bought into 3HP. So we likely will not be delivering 3HP to that country before the end of the first period of the grant. Here's the packages that are arriving in some of your countries, and you know what to look out for. So as the question answer in the poll beginning was around the top row, which is the current formulation with isoniazid, rifapentine, and pyridoxine, comes in those boxes. Think about what that means for a supply chain. It comes in separately. Sometimes the isoniazid is already there or arrives early. The rifapentine took some time to get to our countries, taking out the blister packs, cutting them apart, putting them into kits and giving them to a patient. Once every month they come back, or some countries have moved forward and given all at one time. But that's still a little bit of a complicated regimen. For the poll answer, you can see the answer there, 36, 72, 16, which is quite a lot of tablets for a patient to take. And now we can see at the bottom row, McLeod's has been the first out the gate with a fixed dose combination, which is conveniently one full course in one box, broken down in those aluminum sheets that you can see with 3 tablets across, which the patient takes. And then we have pyridoxine combined with that one for those patients that need it, but it's a much easier way to give 3HP, and it's a much easier way to give it in a DSD model going forward. And then a review on dosing for this product. So again, looking at the amount of pills that need to be taken and what's available in the market. Notice there's a lot of NAs for the children. We do have a FDC that's available, but it's not available for kids. The FDC that's under a research study, TBT 35, which we're co-supporting with CDC, has one, but it's not available on the market. So this is still a big gap area. Also to note on this slide, the complications of dosing for children. Right now, we do have child contacts as part of this grant, including people with HIV, and those children have to receive crushed rifapentine tablets mixed up with food. It's a very bitter pill to take, and it's not something that's really moving easily. So we see a lot of countries choosing to put children on 3HR instead of on 3HP until a better formulation comes about, which we hope happens in our extension period. So just a little bit about our progress going forward. So in the beginning of the grant, and this even started in 2017, which gets to the cost answer here, a full patient course was 45. Now I saw that most people answered that it was 72, and that is true. When we started in the US market, Sanofi was selling that for just their boxes of Prifton for $72. GDF quickly negotiated down to 45. And we were only giving that to about 30 to 50,000 patients globally per year. That has now moved, as you can see on the other side, to a generic coming on board, future generics planning different types of products for 3HP and other 1HP and pediatric formulations, with the patient course of McLeod's dropping down to 15 and the boxes of Sanofi dropping down to 15. Reaching a lot more patients this year, for sure. Now that the supply is cleared a bit more, you're going to see about 2.5, maybe even more, coming on to 3HP, both Sanofi and McLeod's products. It's also noted that we were mentioning the study DOLPHIN, and Violet will give an update on it, but we were wondering, could we give this to somebody taking dolutegravir, a very common regimen in ARVs right now? And yes, we can. The pill burden is very high, and that is one thing that the FDC changed about too. We still have this issue, if rifapentine can be given to children under 2, TBTC 35 will have that evidence, we hope, within a year. But we will restart that. It was paused because of the nitrosamine issue, which I'll get into. And can rifapentine be given to pregnant women? That's something also that will be addressed by Violet, but we do know there's studies going forward that will help us answer those questions. So the other question was around how many countries have started patients on 3HP, and it was specifically the fixed dose combination. So I would like to note that 0 countries have been started on the fixed dose combination. We have boxes unpacked and going to sites in Mozambique to be launched on World TB Day. Patients will start next week. Ethiopia also has boxes. Bangladesh has some boxes going on. So we have not started, but the orders are moving, and your country might have ordered some. But where we have 3HP and the Sanofi single formulation under this project are listed below. India and Brazil are there. They've ordered, but they haven't been able to receive their orders yet. And you can see the timeline there on the initiation of when our countries under our project started. I will acknowledge in a further slide other starts that have happened under other donors as well. And here we go with all the group of wide donor support for this. So we needed to get a lot of people living with HIV on 3HP. And as you can see in the targets from the World WHO TB report, we've hit those targets pretty well for people living with HIV. It's come about because of this support that largely came through PEPFAR and Global Fund, demanding it in their grants and definitely putting it into their COPs. We have other partners acknowledged, I'm sure I'm missing some here, that are working in countries that were also starting 3HP. USAID through other TB funding has made that happen. PAHO and the World Health Organization have also been bringing in a lot of 3HP to their countries, and Gates Foundation has been supporting some evidence-based work around 3HP. So by this time, 2022, you'll see most of these countries with orders, hopefully by the end of this year, that are listed under the PEPFAR and Global Fund grants. And we hope going forward that the transition to a Global Fund also supporting a lot of 3HP for household contacts and children will be occurring. And we just introduced it into a lot of our countries. So one of the big limiting factors besides COVID this year was this impurity issue. So just as a summary, And I think noting the piece at the top, the known risks of not treating or preventing TB outweigh all of the theoretical risks that have been done in the analysis of nitrosamine intakes. So Sanofi reported in about June of this year, 2020, that there was a nitrosamine level that was raised that they were questioning. They did some further studies to understand what the limit of that intake could be that would be safe for people, especially under the different regimens that are available for rifapentine and rifampicin. For rifapentine in adults, batches were tested and cleared to have a temporary limit of 20 parts per million. I've highlighted that in red. Going forward, the Sanofi and McLeod's products will all be tested to ensure those drug products have that limit. Sanofi has resumed their production in 3030, which is really far out. So it's actually 2020. And they've received clearance for the FDC as well through the Global Fund ERP clearance process. And those limits and those boxes being sent out of McLeod's also have that limit. The goal is suppliers would do additional testing to reduce those levels down to 0.1 parts per million if possible. But by doing this and all the work that's required to reduce this nitrosamine content, it may increase the price of the products. But right now we see that all prices are staying the same through 2021. For the pediatric versions, there were some additional assay results that were just coming out in March of 2021 around this water dispersible rifapentine formulation that show that it is also well below 20 parts per million, which is great. So now we need the FDA and IRB approvals to follow that, to start up some of the studies that were using that product. And then we know that rifapentine for kids has some options, but the best option through the PADO and GAPF working group came out to recommend a 150 milligram single dispersible, not an FDC product. So we're going to see how that all works out and gets developed by these manufacturers over the next few years. And lastly, on my bit, I wanted to give a congrats. I know Zim is coming on to talk a bit more about what they're doing, but the work that TAG has done through the CSOs and the support of patient advocacy and patient education to move information about TPT. One great example of this was the scale up in Zim. So Zim was one of the first to get their rifapentine Sanofi single products. They moved it, and guess what happened? COVID happened. So they immediately took a great decision and policy to give 3 months supply instead of making the patient come into the facility at risk of COVID. Then they also got the real-time information around the rifapentine impurity issue out quite quickly. They were able to do it in a DSD model because all the implementing health facilities were getting airtime to follow up with the patients to see if there were any adverse events or if any problems were happening. And it came about through a cooperation of the CSO with DSC leaders, the sites, the community health workers to help with patient follow-up and the screening and IDing of those adverse events. And we hope to see other models of this as we continue to roll out 3HP. So now I'm going to move over to introduce Violet to give us a bit more about the evidence side of our project. Over.
Thank you, Karen. Good morning, good afternoon, good evening, everybody. Thank you for the opportunity to present to you. So as Karen mentioned, the Impact for TB project is not only implementing 3HP across 12 countries. In addition, we are also generating evidence to inform policy and guidelines. This diagram clearly shows the different outputs of the project, and I'm going to be focusing on the generation of evidence within the project. Next slide, please. So the dosing and safety of 3HP with adults on ARV regimens was largely unknown in 2017. So that was prior to implementing the Impact for TB project. And similarly, rifapentine has not been studied in children under the age of 2 years or in young children with HIV, despite, the development of a formulation of child-friendly fixed dose combination of 3HP that dissolves in water and tastes like mango. So basically, there's clearly lack of evidence to inform the implementation of 3HP. Next slide, please. So then to this end, we are conducting a number of clinical studies and implementation research studies to inform the implementation of the short regimens, in particular 3HP. In 2017, we also began planning a study that we call the DOLPHIN study. I think you've heard a lot about the DOLPHIN study. So the DOLPHIN study was basically a phase 1-2 study of 3HP and dolutegravir in adults with HIV who were virally suppressed. And the primary goal was to characterize safety, pharmacokinetics, and virological suppression. The study was conducted in South Africa, and we basically found that 3HP can be given for TB prophylaxis to patients with HIV who are taking dolutegravir without dose adjustment. So this was the key finding from DOLPHIN, which then helped inform policy and guidelines. Next slide, please. So as mentioned earlier, so the first DOLPHIN study was focused on adults who were virally suppressed, but we then realized that there was lack of evidence as well, or lack of data around people who were newly initiating dolutegravir. So we then amended the DOLPHIN study, and we currently planning to implement the DOLPHIN 2 study, which is going to be looking at treatment naive individuals, so answering the same question. As mentioned by Karen, we've had a number of delays due to the issue of nitrosamine, and as such, the product for DOLPHIN 2 has been on hold, but the protocol is approved and we are ready to open the study for enrollment. The study is being conducted in South Africa. Next slide, please. So we then extending as well the DOLPHIN study to kids. As mentioned again by Karen, there's lack of evidence in children, and the one thing that we know for sure is there's no clarity on guidelines in terms of what to do with these newer shorter regimens of TPT. So in the DOLPHIN Kids study, we will include basically individuals with HIV taking efavirenz, nevirapine, or lopinavir, and 2 nucleotide reverse transcriptase inhibitors. And this study will only start in March 2020 and would be part of the extension that Karen mentioned. The study is being done in South Africa, and post-treatment access to pediatric dolutegravir would be made available if needed. Next slide, please. So those are basically our clinical studies, and moving on now to the more implementation research studies. We've got a number of studies that we are conducting in some of the impact for TB countries, so not in all 12 countries. One of the studies we are conducting in Malawi, Mozambique, and Zimbabwe is the choice architecture-based TB preventive therapy. And this is really focusing on the practice of prescribing TPT to patients. And it's one of those studies that's evaluating models of delivery of the short regimens. As you can imagine, we need to kind of come up with models that will efficiently allow us to efficiently implement 3HP. So the CAT study is actually testing whether the choice architecture approach of a default to prescribing TB preventive treatment substantially increases 3HP prescribing. So in this study, which is a cluster randomized study and is a pragmatic one, we are conducting this within clinics that are implementing TB preventive treatment, and the choice architecture is basically an opt-out to 3HP prescribing, where prescription of 3HP will automatically be included with HIV medications, unless, of course, the clinician write an order not to prescribe. So in this instance, the clinicians are opting out. And as mentioned, it's in 3 countries and it will be conducted over a period of 24 months. Next slide, please. Again, looking at models of delivering TB preventive treatment, we know it's a big challenge delivering TB preventive treatment, particularly in child contacts. And this specific study is comparing the effectiveness and cost effectiveness of community-based versus facility-based child contact investigation and delivery of TPT. And again, it is a pragmatic cluster randomized trial of community-based contact investigation and initiation. It's being conducted in South Africa and Ethiopia. And nested within this study is a qualitative component. And the qualitative component will describe the social context for delivering community-based TPT. And using data from the qualitative study, will then develop context-specific adaptations to the intervention that we are proposing. And really, this is to allow us to maximize the effectiveness of the model. Next slide, please. And moving on now to one of the most recent studies we are proposing, the 1-2-3 study. Some people have said you should actually have called it the 3-1 study because this is a study looking at it's evaluating 1HP, which is an ultra short regimen, TB preventive treatment regimen versus 3HP. And the study will enroll HIV-infected individuals, and these are adolescents and adults. And we will also include HIV-uninfected individuals. In this case, this would be household contacts. And the study is primarily comparing treatment completion and treatment-limiting adverse events between 1HP to 3HP. The study is proposed in 4 countries, South Africa, Indonesia, India, and Mozambique. And this is to allow us to be able to at least generalize the data in different populations. We plan to start the study in October 2021, but again, this is dependent on us getting the costed extension approved. Next slide, please. And then the other risk group we are looking at are pregnant women. And as you would know, the highest TB risk for a woman is during pregnancy and immediately postpartum. Maternal tuberculosis can result in poor pregnancy and infant outcomes, including neonatal TB. And the challenges are there's unclear guidance on TB preventive treatment in pregnancy because there's very limited data. And so, I mean, we do know that the short-course TB preventive regimens in pregnancy can be completed during pregnancy and could really avoid postpartum risk of hepatotoxicity. And rifampicin is not recommended for pregnant women. And this is basically because there's absence of data. So really underscoring the need to collect more information on the safety of these preventive regimens in pregnant women. The WHO continues to recommend that pregnant women with HIV have the option of taking IPT. And so we're hoping that through a series of studies, we'll be able to provide evidence to inform this. So oh, sorry, this slide has moved. Sorry. So again, there's limited data on drug-drug interactions with dolutegravir in pregnant women, and women without HIV as well will constitute the population where evidence is needed. Next slide, please. So as part of the Impact for TB project, we are proposing to support a 3HP, 1HP study in pregnant women and proposing a phase 4 randomized controlled trial looking at safety, tolerability, pharmacokinetics of 1-HP versus 3-HP. And this population will include HIV infected and uninfected pregnant women. Specifically, we are going to be collecting data on targeted safety events. The study will likely take 48 weeks postpartum, and we are proposing to do this in up to 4 countries again to be able to generalize the findings. Next slide, please. And then I think the one thing Karen mentioned was there's a lot of funder support to collect evidence around implementation of TB preventive therapy, treatment rather. And one of the studies which is leveraging the Impact for TB project is the Opt for TPT, which is really optimizing delivery cascade for TB preventive treatment. And this is a project funded through the Bill and Melinda Gates Foundation with our partners Johns Hopkins, KNCV, CHAI, and MOH, Ministries of Health. The study is going to be done in South Africa, Ethiopia, and Zimbabwe. And the goal is really to generate critical knowledge to improve TPT uptake, implementation, and outcomes. And we will be describing patient journeys, clinic level processes, and explore patient preferences for TB preventive therapy. And also nested in this is a cost effectiveness analysis. Next slide, please. And just to acknowledge our funders and partners, thank you very much.
Thank you very much, Violet and Karen, for the presentation. So I know we're a bit over time, but maybe let me turn to Ajay with just one question from from your session. So there was a question that was asking whether there's, the subject of once in a lifetime TPT versus repeating TPT every 2 years. I don't know if you would provide some comments on that.
I can provide a little bit, not too much perhaps, but I will say that I think the current evidence suggests that providing 1 dose of TPT is very effective in preventing TB. And I think I covered that very briefly in my slides as well. And, I think slowly there is a growing body of evidence that TPT tends to be between 60 and 90% effective. And I believe there's one particular longitudinal study, I believe in based out of Canada, where they showed that TPT may have up to 17 years of protective efficacy. And I do understand that there was a comparison of 3-HP versus P3-HP recently, which showed similar rates of TB incidence, and that the only key difference was that there were potentially more severe adverse events in the arm that basically received 3-HP twice. So yeah, thanks.
Thanks a lot, Ajay. With that, we'll move over to the second segment. Other questions we'll attempt to address in the second Q&A. Let me introduce our next speaker, who's Chlorata Gwanzura from the Zimbabwe Ministry of Health and Child Care. Chlorata is a public health specialist with the HIV and TB unit of the Ministry of Health in Zimbabwe. She is responsible for TB preventive therapy differentiated services delivery at the national level, as well as serves as the focal point for community collaborations. Welcome, Chlorata.
Thank you very much, Aki, and thank you for the introduction. So since I've already been introduced, I'm just going to go straight into the presentation. My apologies, I think my slides got stuck.
You may want to close the PowerPoint, then bring it back.
All right.
To share your screen.
Thank you. I think it has started moving. So this is going to be my presentation outline. So I'm going to give a brief country context, talk about implementation of TPT in Zimbabwe, and our experiences from the 3HP introduction, and then a brief conclusion. So a background on Zimbabwe, we are one of the top 8 countries that are heavily burdened.
Clarissa, if I could come in, I'm not seeing your slides.
You are not.
Yes.
I go
Maybe
to
just
reshare, and this will be fine.
Yeah, reshare.
Okay. I'm so sorry about that. Let's see. Yeah.
No worries. Perfect.
Now you can see. All right. Thank you very much. I was going to keep going without the slides up. So we are one of the top 8 countries which are heavily burdened with TB, HIV co-infection, and also MDR TB. Our current HIV prevalence stands at 11.8%. However, women have got a higher prevalence compared to men. The number of patients who are currently on ART is 1.18 million. Our TB prevalence is 221 per 100,000. And childhood TB accounts for 7 to 8% of our annual TB notifications. So you see that we have quite a burden there. So in terms of TB, HIV collaboration, collaborative activities, the country adopted the 2004 WHO interim policy. And so we worked on strengthening collaborative mechanisms between the national TB and AIDS programs. We instituted the 3 I's in implementation, and we also have activities to reduce HIV burden among TB patients. Our policies and guidelines also are adapted to cater for TB, HIV collaboratives. So we have policy supporting enrollment of people living with HIV on TPT. We have task shifting and task sharing, one-stop shop for TB HIV management, and we also have a policy on multi-month scripting, which was highlighted in Violet's presentation. Our ART guidelines, they also have guidance on initiating people living with HIV on TB preventive therapy. And this is also in our operational and service delivery manual, which is basically the guidance that elaborates the implementation of our ART guidelines. Then for coordination, the National TB Program and the National AIDS Program are housed under one directorate. We have an TB, HIV, TWG. We have TB and HIV Partnership Fora, which meets quarterly, and also our M&E tools capture TB and HIV data and indicators. So we started off with a pilot in 7 districts in 2012, and over the years up to date, we have increased the number of facilities which are implementing and reporting on TPT, and currently we have about 95% of our health facilities implementing TB HIV collaborative activities and enrolling patients on various TPT regimens. And to date, we have 635,000 patients who have been enrolled or initiated on TPT since the program started. So basically, we strengthened counseling of clients on IPT, synchronized INH with ARV pickup and spacing the medicine pickups to 3 months, and we also adopted 300 milligrams versus the 100 milligrams that we're using initially. So this table is showing our current guidance on TPT regimens in country. So our preferred regimen for PLHIV on efavirenz and DTG-based adults and also children on efavirenz-based regimens is 3HP. That isoniazid remains the preferred regimens for those adults on TAF, PIs, and NNRTIs, and children on DTG-based regimens, protease inhibitors, and NNRTIs. So implementation of 3HP, we started with a feasibility approach, and this feasibility study was going to be undertaken in 20 facilities, but because of the various challenges that we faced last year due to the COVID response globally, we only managed to start implementation in 6 facilities. So the 20 facilities that we were supposed to implement in are the ones that you see in the 2 tables. And the color codes are just showing the province that each of those facilities is in. So the red is Bulawayo province, the blue is Harare, orange is Matabeleland North, green Mat South, and then the lilac is Midlands. So far, we have about 3,500 PLHIV in contacts who have been initiated on 3HP, and of those, 1,600 have completed so far. So the facilities are like Harare, Highfields Polyclinic, and Glenview. Those are the ones which started earlier, and Mpilo. So that's why you see a bigger number of patients who have completed. We are still collecting data for facilities like Shurugwi Hospital, and yes, and Glenora Satellite. But Glenora Satellite currently the facility has been closed, so that's why we also have a smaller number of people who have been enrolled in 3HP. So coming to our experiences, I've divided these into experiences at inception and then experiences at follow-up. So at inception, what we quickly realized was that having had the new guidelines disseminated to the sub-national levels before we started the study was an advantage for us, because it greatly assisted with takeoff of the project. We didn't have to do as much to make sure that people understand 3HP, what we needed to do, and how to manage adverse events. What we also noted, one of the things that we were struggling with in terms of the program was there wasn't a clear grasp on the science behind TPT. So in this time around, when we are starting with the program, we noticed that sharing the science behind the programs improves barriers that we had with healthcare workers in terms of program implementation. So we had to share a lot of information on studies on effectiveness, expected rates of adverse events, just comparing them to other adverse events of the drugs that we are already using in the system, and also management of adverse events. And we saw that this greatly improved acceptance of the program by healthcare workers. And then frequent site support was needed initially, especially in the very, very new aspects. Like in this case, we have adults on DTG-based regimens taking 3HP, but children on DTG-based regimens not yet are recommended for 3HP. So those were the things that we needed to support healthcare workers on until they had really gotten a grasp on the differences between the two. And then we also had to provide airtime support for all the participating facilities for a follow-up of clients who had been enrolled on 3HP, and this was largely also because of the COVID restrictions which were going on. And then during follow-up, we had to task shift so that we improve outcomes. So we shifted tracing of patients in the community or contacts to environmental health technicians and community healthcare workers. Then patient follow-up, the week and month, the 2 week and the month one, we had also to shift this to primary counselors so that we reduced the burden on nurses who were failing to follow up with all the clients who had been initiated and document that these clients had been followed up. So when we did the task shifting, we noted an improvement in documentation and also a faster pickup of adverse events. The other thing that we noted was that it's feasible for us to do multi-month dispensing for the new regimens. This was already a policy for INH, and we also wanted to see if this was possible with 3HP, and we noted that this was possible because this is what we do. And one of the enabling factors was also the COVID response. People were not able to move around. So we had to also quickly move to do that. And we noted that it was possible for us to do that. And then tele-follow-ups. So we were using phone calls to follow up on patients. Generally with everyday implementation, patients had to come back for us to review them at the different time points that would have been appointed. But in this case, we had to follow up the phone call. And we saw that it was still, we still had good outcomes. We were still able to pick up clients with adverse events who were not really that many, but it was one of the ways that we noted that it's actually something that can be implemented even as we scale up. And we also noted that recipients of care are keen on shorter regimens. So once we had clearly communicated the new regimens, the benefits and expected adverse events, we noted that people were keen to take these up, and demand has been created even in facilities that are not yet implementing 3HP. And then because of the nature of the dosing, the weekly dosing, and all these other things which I mentioned, capacity building for healthcare workers, etc., we noted that there was improvement in TPT uptake in these participating facilities. So some of the challenges that we faced and the proposed solutions, we had delays in supplies for 3HP, and I think the majority of all programming is talking about how the COVID response affected our implementation of, all our programs, HIV, TB, etc. So we also had these delays and had to limit the number of participating facilities. And because of the single dose formulations, there was increased pill burden. And so we noted that uptake was lower or a bit compromised in the younger people and adolescents. And then we also had industrial action from some of our facilities, which also affected implementation. These facilities were supposed to be participating, but programming was then affected because of that. So to try and address these challenges, what we have done is our current ordering assumptions, they have been made with the anticipation of the delays, especially after the second wave. We noted that we are going to experience more delays. So we have made our ordering with those assumptions, but recommended and are still continuing implementation of TB preventive therapy using IPT. And this really was to avoid implementation interruption. And then to address the single dose formulation orders, the pill burden, we had to cancel the orders that had been put initially with single dose formulations in favor of the fixed dose. So all our orders now have been done for the fixed dose, and we are awaiting those, the delivery of those, and then scale up to the rest of the facilities, not just the ones that are participating in the study. And also the Ministry of Health is working on addressing the workforce issues in the facilities where there was industrial action by healthcare workers. So in conclusion, we have managed to scale up TPT service provision, and we believe that the use of optimized TPT regimens such as 3HP is a potential game changer in terms of uptake, coverage, and also our completion rates. Managing messaging and also appropriate management of adverse events increases confidence and addresses myths and negative attitudes towards TPT, and this also increases demand for TB preventive therapy. Management of healthcare worker attitudes I've already highlighted too. is key to programming as well as strengthening pharmacovigilance, since the issue about adverse events was also an underlying issue in TBT programming, especially when we're implementing isoniazid. And then strengthening of community TB and HIV activities contributes positively to the fight against TB among people living with HIV. This is my last slide. Thank you very much. Over to you, Ike.
Thank you very much, Cloretha, for that nice presentation, well timed as well. Moving on to the last presentation, I would want to welcome Proscovia Namuwenge from the Uganda Ministry of Health. She's a senior program officer at the Ministry of Health and the national coordinator for advanced HIV disease at the AIDS control program. She also coordinates the national TB HIV response at both the national TB and leprosy control program, as well as the AIDS control program. I understand, Proscovia, you may be having some connectivity issues, but let's see if your connection has improved. Otherwise, we'll just go ahead with the recording you had shared. Over to you, Proscovia.
Okay, thank you so much, Iki. Hi, everyone. I'm here to share with you our experience on Uganda's 100-day TPT scale-up approach, results, and the lessons learned. My name's Proscovia Namuwenge. I work with the Ministry of Health in Uganda. As a way of background, Uganda in 2014 adopted the WHO guidelines for intensified TB case finding and IPT as part of its comprehensive strategy for care for HIV/AIDS. And IPT implementation, however, suffered impediments like limited resources for procurement. There was suboptimal allocation of INH to the facilities, and this was also paired with disorganized distribution of these commodities, whereby you would find INH being distributed to facilities and not paired with the pyridoxine, but also you would find high volume facilities were given less quantities compared to what they required and things of that sort. There was also lack of proper preparation in that we lacked registers for documentation of those people who are enrolled on IPT. So this in the end affected the early implementation of INH, and we realized that from June 2014 to about June 2018, only 40,000 PLHIVs had been started on INH, and out of these, 69% were documented to have completed. So as a way of trying to improve our program implementation of IPT, July 2018, we started what we called the Surge Quality of Care Initiative to try and focus on all those indicators that were performing poorly, including the IPT coverage. But even with this effort, little progress was realized on IPT indicators. So the country decided to plan and implement what we called the 100-day IPT scale-up campaign. And why did we decide on this? It's because Uganda had set an annual target for IPT enrollment to target to reach about 500,000 from October to 2018 to September 2019. And we wanted to reach at least a coverage of 50% of those active in care. And we realized that despite the efforts like Surge that I had mentioned earlier, we had only improved minimally from 5% to 19% by June 2019. When we assessed our stock situation in the country, we had sufficient stock to enroll at least 500,000 people. And because of this, whatever was available in the country, we decided that let's plan an accelerated scale-up plan to enroll the remaining target for that year for IPT in the remaining 3 months. And after the planning, the occasion was launched by our Minister of Health to try and give it mileage. So what did we do? We developed our accelerated IPT scale-up plan with the following objectives: to ensure sustained and adequate availability of isoniazid and pyridoxine at health facilities, which were prioritized for IPT implementation. We prioritized certain sites because of the numbers of PLHIVs that were there, and we were looking at those facilities that could give us the highest coverage in the shortest time possible. And the second was to provide ongoing guidance on IPT to health workers at all implementing sites. And the third was to ensure availability of appropriate job aids and tools for implementation. And lastly was to strengthen monitoring for IPT implementation in the sites that were prioritized. We had strategies to achieve our objectives, and for ensuring availability of commodities, we started by phasing the IPT scale up so that we could learn from the few sites while we scale up to more sites. So we phased this in about 3 phases. The first phase, we started with about 52 sites. That was from October 2018 to March 2019. And from these few sites, we learned how best to go ahead by increasing on the number of sites, but also on what instructions to give to the health workers. Second phase, we scaled up to 147 sites, and that was from April to June 2019. And third phase comprised of what we had in the campaign, a 100-day campaign, which was meant to help us achieve our 50% coverage. And this was scaled up to 382 sites, implemented from July to September 2019. And our phase 4 is what we thought would be our mop-up phase to all ART sites to reach a target of about 90% coverage. And we also, as a second strategy, we developed guidance to health workers to commit, and here we gave them guidance to commit 6-month course stock for every INH for every PLHIV that was enrolled, and instructed the national warehouse to ensure that for wherever INH was distributed, they should be paired with pyridoxine. And for the health workers, we also emphasized that reporting on IPT enrollment should be done using an interim reporting tool, which we called the Surge dashboard. Third, we allocated targets for prioritized sites to make sure that the health workers knew how many PLHIVs they had to enroll within the 100 days. And we also worked with warehouses to ensure that there was optimized distribution of commodities, and in that we were monitoring the stock. Where facilities still had stock, we would be able to instruct the warehouse not to distribute INH there, but to take it where they needed it most. And our second objective was to ensuring technical capacity. Here we held several national planning and consultative meetings. And during these meetings, we gave guidance on what to do. For example, our guidelines at that time were targeting only new PLHIVs for INH. But during this time, we developed an expanded target group for INH to include all PLHIVs who are in care, as long as they had not got an IPT course. Then we conducted national and regional TOTs to refresh health workers' knowledge on TB preventive therapy, and also conducted facility mentorships on the same. The sites which were starting to implement INH programming, we gave them 2-day on-site mentorships, and those which were already in the practice of providing INH to their PLHIVs, they were mentored for 1 day. What we did during the mentorships at these facilities, we conducted CMEs on isoniazid preventive therapy. Then after the CMEs, we went into patient files and counted numbers of eligible PLHIVs who were due for INH. And these included the new PLHIVs who were in care, all the eligible active in care who had never got a course of INH, all the under 5 contacts of PBC patients. And we also counted the numbers that were currently on INH and those that had ever received INH, so that we could discount it from those that we had counted in the upper groups to be able to know how many PLHIVs were pending to be enrolled on INH. And after counting the numbers, we would also go ahead and quantify the available INH on site to be able to know how many PLHIVs could be enrolled with 6-month courses on this INH. Then we reviewed client files and line listed those to be screened for IPT so that they could be followed up and be enrolled on INH. For our third objective, we to ensure availability of appropriate job aids and tools. The Ministry of Health, with support from partners, printed over 1,500 IPT preventive therapy guidelines, which were meant for the health workers to read and use as reference points. But also, we developed or designed the isoniazid quantification chart, which was to guide health workers on how much isoniazid to give for the different weight bands of the patients they were taking care of. Then for monitoring, we held weekly performance meetings at the national level, and this was done by the national task force that had been formed for this purpose. And we also, working with implementing partners, they supported the health facilities to record and report IPT enrollment and completion in the weekly HIV/TB surge dashboard that had been designed for monitoring the poorly performing indicators, but also on a quarterly basis to make sure that this information was put into the national HMIS database, the DHIS2, and also the implementing partners made sure that they support the facility to fill in the web-based ordering system for TB drugs to make sure that they put in the right requisitions for the medicines that were required. We also, on a weekly basis, shared performance of how implementation was and performance was to the facilities and the implementing partners that were taking care of these regions to make sure that they have a way of following up and knowing how they are performing. So that is a way to show how our surge dashboard looks like, and it is able to show us the progress of enrollment over time on a weekly basis. Our results over time. So this graph is showing us the trends of IPT enrollment since we started. Much as we started 2014, I commented that we had no documentation, so it was very difficult to get those numbers. So we see that from 2015, we had a low of 5%, but and by June April, June 2019, we were at 19%. That's when we decided to have the 100-day IPT scale-up campaign. And for that period, you see that we were able to improve from 19% to around 52% by the end of September 2019. And thereafter, we have continued to enroll PLHIVs on INH, and we are by December 2020, we had reached 71% and enrolled at least about 856,000 PLHIVs on INH. Currently, we are standing at about 73%, but since our data is reported in quarters, I didn't want to put that there because the quarter is not yet complete. The lessons we've learned from this is scaling up IPT is possible with meticulous planning, and political will is crucial in adding mileage on lagging behind and programs that are lagging behind. Collaboration between stakeholders is very key if we are to realize success. In our campaign, we specifically worked with all the key stakeholders, the National TB Program, the HIV program, the implementing partners and civil society organizations, including the PLHIVs themselves. And we also worked with the national warehouses to ensure that the drugs were properly distributed. Thank you very much. That's our experience. Oh, sorry, our next steps. We are now in a mop-up phase. We have developed a catch-up plan where we've set targets for the remaining PLHIVs to be enrolled, and facilities that have line-listed PLHIVs that are pending. Because after the campaign, as you saw in the graph, there was a bit of stagnation, but we are now have re-engineered our scale-up campaign to make sure that everyone that hasn't got an INH course should be able to get it up to at least a coverage of 90%. We conduct redistribution where IPT and pyridoxine is needed most, because some facilities tend to get all their clients enrolled and they end up with a lot of INH remaining. Then we hope that when 3HP becomes more available, we shall also start some of our new PLHIVs on 3HP. Thank you very much.
Thank you very much, Dr. Proskovia, for that very interesting presentation from Uganda. I'll crave the indulgence of participants if we could have an additional 5 minutes of your time. I think there are two important questions that were submitted as part of the registration process to this webinar that I would possibly want us to get to. First is on the causes and prevention of TB relapse. I think that's a very important question that was submitted, and I'm tempted to call on you, Ajay, if you could comment on that, or any other of the participants or the panelists.
Sure, one sec, sorry, I'm just unmuting myself. So I think, where do I start? I think, yeah, I just think, sorry, in the interest of time, I just think it's easier to perhaps just sort of look at the current operational guidance that we have to ensure that patients, patients who are undergoing treatment stay on treatment. I think some of the key aspects are, really preventing treatment interruption. I think that's really vital. And I think also, sort of having the patient-centered approach to, properly informing those who are on care. I think particularly this becomes even more important in the context of people living with HIV, as there's this issue of polypharmacy as well. So I really think that, it's sort of this combined decision making. And I think it's quite an extensive list, and I think it would, yeah. So I've also shared all of the documents in the chat. So for those who are interested, you can really get into the weeds in the specifics. Thanks.
Thank you very much, Ajay. And to maybe mention also substance abuse, which is one of the things that could also lead to relapse. Last question would be to the Aurum team. And Karen, maybe let me turn this to you. I wonder, for countries, a lot of countries that have participated on this webinar today are not part of the Impact for TB network. So I don't know if you're able to give an indication of when countries that are outside of the Impact for TB network could expect to have supplies of 3HP come their way. Over.
Sure, especially that FTC product. I think just to note, the FTC that's arrived is expiring stock, so it's special countries that got it. So McLeod's has just cleared WHO ERP approval. It's almost there with WHO PQ. So the FTC should be available and ready to order through GDF, through WAMBO, through PEPFAR. All those donors are definitely supporting the catalyzation of this product across countries. We have Brazil and India also ordering, and South Africa through tender processes. So it is available. And through this clearance process, through the ERP process, just happened 2 days ago, you're going to see a lot more availability of the product, which has been very restricted up until now. We hope to have new generics joining the market in 2022, 2023, which will also increase the supply, and then also provide options for 1HP to be co-packed better than it is right now. So please contact your donors. I think all donors that are supporting people living with HIV are definitely there. Global Fund grants are being reprogrammed to include purchasing of this new short course regimen. So you don't need to be an Impact for TB country to access the drugs right now. Thanks. Over.
Thank you very much, Karen. I'd like to use this opportunity to thank all the panelists, thank our colleagues at CDC Foundation, Unitaid, as well as you, the audience, who have stayed with us this long. Just to say that apologies for not having the kind of time we would usually dedicate to live Q&A. We're considering having a session that would really revisit this topic and have decent amount of time for Q&A. So that's it from every one of us. Team Echo, thank you as well. And have a good evening or good morning or good day, depending on where you've signed in from. Thank you very much.